This is This is our third session, third series of the foundation course for palliative care for allied health workers, counselors, social workers. And I couldn't be more pleased to see so many people sign up for this. For a very long time, the trainings were concentrated around people with medical education and training, which is wonderful. But I personally, and this is my personal opinion, believe that being a multidisciplinary field, palliative care, especially of all the disciplines, relies heavily on the wisdom and contributions of those of us who are not medically trained but have the heart for social service. And to have so many people join this program is just validation of the fact that there is so much room yet for us to learn. Um, I had a really great time putting this whole curriculum together with the entire team at Pallium India, and with such valuable insights and contributions from all our faculty who are really friends of Pallium India and palliative care in general. So welcome everybody. And today I have the distinct pleasure and privilege of introducing our facilitator. So the first time we did the FCPC course, we didn't have this particular module, which is palliative care in humanitarian settings. And it's poignant because we didn't think we needed it at that point. But the pandemic has, of course, changed that perspective. And now today, all of us find that we are not only working in a field that is inherently challenging, but we're working in a field that is challenging within challenging times. And it calls for all of us to really view the suffering that people around us experience, which is compounded by the difficulties that a pandemic or a humanitarian crisis places on us. But there have been people who had the vision to look into this aspect well before the rest of us got there. And my privilege today is to introduce one of those very special people, Joan Marston, who is a dear friend and one of the leading lights, as far as I'm concerned, in palliative care globally. Joan is from South Africa. She's joining us from South Africa today. She has a background in nursing and social sciences and has been active in hospice and palliative care for 32 years, which is a lot of experience that we have to draw from today. She's been involved both at the local level, the national level in South Africa, as well as at the international level, and has been a strong advocate for palliative care practices everywhere. She was the Chief Executive Officer at the International Children's Palliative Care Network, a position from which she has now retired. But then she didn't stop there, of course. She went on to co-found Palliative, which is palliative care in humanitarian aid situations and emergencies. And like I said, one of the most badly needed areas of work today. She is now, and Palchase is now also part of the Global Health Academy of the University of Edinburgh. She is also on the executive committee of Palchase with a special responsibility for advocacy. And in the course of this program, we will also be touching upon how important it is for us to be advocates, not just to provide the service, but also to advocate for those to whom we serve. And that's a very important component of this program. And over the years, Joan has contributed to a number of publications. She's been part of several WHO working groups and global advocacy initiatives. She teaches, she has done a lot of research, and has been in, I think, every conference that I've ever been to, and right through her career. And Joan has a special interest in spirituality in children with palliative care needs. So I can go on and on and on about Joan, but I think that would really cut into the really important stuff that she has to say to us today. So Joan, very welcome. And over to you. I'm here to co-facilitate and to help you out as we go along.
Sorry. Oh, thank you so much. Thank you so much, Smriti, for that lovely introduction. And thank you for inviting me again to come. I really feel so much part of Pallium India, and it's one of my very favorite places in the world to be. So thank you. And greetings from South Africa. So we're going to start screen sharing, but before I do that, I would like to just give you a little bit of background as to how I got involved in this field. And I think Many of us can remember a few years ago when the war broke out in Syria, seeing this unending stream of refugees. It just never seemed to end. There were children, there were teenagers, there were middle-aged people, there were the elderly, there were the disabled. And because I was part of the global advocacy group, I just thought, well, let me put this question out. What is happening about palliative care in humanitarian crises? And of course, the answer that came back was there is a few things happening around the world, but in general, there isn't a really coordinated group that is looking at this from a palliative care point of view. But I found there were a number of people who were still interested in it, including Savita Butola, who many of you know, and who is now on our executive committee, although she is so busy that she can't participate in everything that we do. And so that is how I got involved in it. And I was also fortunate in that time in that I was working in various parts of the world where I could go and visit refugee camps, see what was happening, and finding like-minded people. And I think it's because palliative care is about the relief of suffering, and so is humanitarianism. And so there are so many areas where we actually overlap, and there's so much we can learn from the humanitarian field as well. So it's not just a matter of us trying to teach them. We have to be humble enough and open enough to realize they have so much that we can learn from as well. And so this collaboration is, I think, the beginning of a new field in palliative care, and hopefully a new field in humanitarian response. So I'd like to just do screen share now. Let's see. Oh, it says the host is disabled participant screen sharing. Okay, so I'm co-host now, so let's try again. There we go. Let me see if this is, no. It's not happening. The relief of suffering is the overarching goal of both palliative care and humanitarianism. And you don't have to be a doctor or a nurse or a medical professional to actually be part of the humanitarian response. The little lady sitting there with children around her and one on her lap is Sophie. Sophie is known to a number of us and is known to Smriti. And she has a master's in global health, but she travels to some of the most unsafe areas of the world to take her passion about especially pediatric palliative care. And she doesn't go into the big medical response groups. She goes into the homes and she does, as she said, she does the small things, but that make a big difference to these children and families. So don't let the thought of being in humanitarianism put you off, because I think it's something, if you have the heart for it, that you can get involved. And I think we all know, because you have done already the introduction to palliative care, that the goal of palliative care is the prevention and the relief of suffering, and the prevention and relief of the whole person. And when we're looking at something like a humanitarian response area, it's the prevention and relief of suffering of a huge number of people across all ages and often of very different cultures as well. And so if we look at what palliative care is, it really does make sense that it should be integrated into the standard responses to humanitarian disasters. And it reminds us of that universal truth that we are all mortal and we're all part of humanity. And I think palliative care and humanitarianism recognizes that we are connected, that we are part of a much greater humanity, and what happens to other people is going to impact on us as well. And as you see from the picture, that was one of those scenes that really had such a profound impact on me. And I thought, I cannot imagine what it must be like to leave behind, totally leave behind all that you've ever known and step out into a totally unknown future as well. And if you have a serious health condition, how much harder must it be to face that? And I've always found it very interesting, if we look into history, is that so much of what happens and so many of these health response organizations came about because of one or other sort of war. From Henri Dunant, who started the Red Cross and from whom the Geneva Convention came, to save the children, to the impact of the First and the Second World War. And then, of course, Doctors Without Borders, or Médecins Sans Frontières, came out of the Biafran War. And SAMS, which is started off focusing on Syria and now does so much else, came about because of the war there. And then, of course, so much of modern nursing came about because of the Crimean War with Florence Nightingale. And while we are washing our hands madly in this time of COVID, she's the lady who really got us started. So what is the need? Well, the need is huge. And if we look at the fact that 1 in every 33 persons on the planet is in need of humanitarian aid, it really brings into focus how many people across the world need humanitarian aid. And that 75% are women and children. And so for us in palliative care, those who are doing pediatric palliative care, who are looking at children, really need to integrate it into their practice as well. And then 86% are in low and middle income countries, many of which have very fragile political systems and very fragile health systems as well. Which is why that there needs to be a global response when there is a humanitarian crisis in these sort of places. And so if we want to look at what it is, we know there are so many different types of humanitarian crises, but it's where there's an event that represents a critical threat in terms of health, which is what we're concerned about, safety or well-being of a community or a large group of people. And we know that this crisis can come from within where we are living. And we only have to look at the collapse of that tower block in Miami to see how a very localized humanitarian crisis could come about. And then there are what they call the complex humanitarian emergencies. And this is where a crisis breaks out in a community that is already fragile, and it may actually cross borders as well. And I think these scenes that I'm just going to show you are those that we see on our television. And I really do hope that we never, ever become complacent about them and inured to what is happening in the world about us. When we see pictures like this, we should be horrified. We should be feeling there is something that we could do. Just really a short list of some of the type of humanitarian settings. It's conflict situations. So we look at places like Afghanistan, like Syria, the natural disasters that we see, volcanoes that are exploding, flooding that you had in Kerala. Then, of course, we see the large numbers of refugees and displaced persons. In fact, there are more displaced persons, internally displaced persons, than there are refugees. And they usually are displaced because there is war or unrest in the country. And of course, pandemics that we are all involved with now, with the COVID pandemic. And those of us who are older can remember the HIV and AIDS pandemic as well. We also have man-made disasters where fires break out that have been started deliberately. We look at the story of Chernobyl and the nuclear fallout there. We look at the disaster that happened in Japan. And then one aspect that we so often forget is chronic poverty. And if you look at some of the scenes of refugee camps and humanitarian settings, and then you go into places where people live continually from generation to generation, often in chronic poverty, there's very little to differentiate between them. And so when there is a humanitarian crisis, the United Nations takes on overall responsibility. and they do a rapid needs assessment. But you will see that health comes a few down in the list of priorities. And you can understand why, because it's really important that everybody is provided with food and sanitation and water and has somewhere to stay. And then the health teams will come in again. And there are many, many different challenges. And that's why we really need to be humble and to recognize that we have a part to play, but there are other things that are hugely, hugely important. And the control of communicable diseases, of course, are very essential. So the overall coordination gets done from the UN, the Office for the Coordination of Humanitarian Affairs. But where we come in with the health response and palliative care, although it looks at every aspect of life, is primarily a health response, comes under the World Health Organization, with UNICEF, of course, primarily responsible for children. So we need to continually ask ourselves, how does palliative care fit in to what looks an overwhelming situation with all these different needs, people without homes, people without clothing, the need to get clean water and food, to provide safe sanitation, because all of these things impact on the health of those who are affected. So when we looked, and this was something that was published in 2017, we found that everyone recognized that palliative care had a role. And yet, when we looked to see where it was integrated, it was in so few places. And then there were really small programs that were doing it. So who provides the palliative care? So where are we as a palliative care group? Who are we going to work with? Where are we going to integrate? Because that is what we feel is important, is the integration of palliative care services, not to have a separate group of palliative care people doing something separately. We need to be working together with all these different agencies who come in. And of course, the first agency that has to take on the health, the community health, the public health, has to be the host country's health system. But as we see, if we look across the world, we know that in many of those countries, they have very fragile social systems and very, very fragile health systems as well. And if we look at the COVID pandemic, if I look at so many countries in Africa, how limited the rollout is of the vaccine that could help to control COVID. Whereas we look at the high income countries where even my 20-year-old grandson has been vaccinated. So the host country, they do the best they can, but then they call in the UN agencies. And then we have this wonderful group of humanitarian health response organizations. The one we, of course, the two really that we know the most would be Doctors Without Borders and, of course, the International Red Cross and Red Crescent, which does such hugely important work across the globe, even in more high-income countries as well, where it focuses on smaller areas of need. And then the global faith-based organizations, which play such an important role, and the whole issue of faith that often plays such a large role in people coming into the humanitarian field. And then on the ground, those that actually do respond. We saw with Ebola, we saw one of the smallest hospices in Africa actually took on the challenge, and how the global hospice movement went out of their way to try to assist and support the Good Shepherd Hospice in Sierra Leone. There was also research done to find out, all the humanitarian emergency organizations said, yes, of course, palliative care is important. But when we went into what was being done about it, when research was done from the University of Geneva, the findings were, in fact, it wasn't generally in culture or practice, unless it was an individual doctor or nurse or social worker or psychologist who had a palliative care background. But, and there's always the lights, aren't there? There are always those points of light, the people, the helpers who come in. And we saw that there were isolated reports of palliative care and pain control. And where refugees had and asylum seekers had come into countries that actually had strong networks of palliative care, we found that some were being picked up within these hospice and palliative care programs. So recognition, but we see that palliative care is very seldom available, both the human, and of course we can have all the material resources that there are, but if we don't have the human resources that are trained, and we weren't finding them in these settings, we found that the essential medicines for palliative care were often not available. And at one stage, WHO had 2 humanitarian packs. The one contained opioids, the other didn't. But what we were finding is that the countries were only ordering the packs without opioids because the regulations in their countries would not allow the packs with the opioids to cross the borders, which was something that had to be looked into. And then, of course, we found that because of the humanitarian crisis, that often there was difficulty for those people who had these pre-existing conditions that needed palliative care. They actually couldn't get to the health centers because of this whole breakdown of structures. And then there was definitely, for many people, this lack of understanding of what palliative care is and how it could integrate into the culture of the organization, but also into the culture of the country where the humanitarian response was taking place. And so I think this picture always gets to me, the idea that some lives matter less is the root cause of all that is wrong with the world. And I think that we can see that with humanitarianism and palliative care, there is an absolutely humanitarian imperative that we do provide it. So from that, we set up what was originally Palchase with 1L until we discovered that there was a group called Palchase, somewhere in Japan, that was doing something totally different, but somehow or other, people were getting confused. And so our original Palchase logo had 1L, but our recent one has 2 L's. And what we are is a network of individuals from palliative care and humanitarian health communities, but all with this vision of the integration of palliative care into the health response, and looking at ways that we can actually achieve this. And of course, advocacy we've done a lot of. The education, there's some lovely education happening in different parts of the world, Bangladesh, North Uganda, Gaza, in Greece. There are so many wonderful things happening, and research has started as well. And so once we've really had a good overview of what is happening, it will be possible to identify those effective models and what works in those models that could be replicated. What we found with the humanitarian health response organizations, of course, is that saving lives was their priority. And what we had to say to them is that you can save lives and relieve suffering at the same time. It's not a matter of either or, it can be both. And then we looked at what are the key areas where we as palliative care practitioners can actually assist in with palliative care interventions. And this was really important to look at because organizations like Doctors Without Borders, like the Red Cross, like World Vision and the Jesuit Refugee Agency, they were doing excellent healthcare. They knew about symptom management. They knew a lot about pain control, especially acute pain control. So where do we come in? And what we found that they especially said to us was around communication. Around how do you talk to people who are in this terrifying, overwhelming humanitarian crisis? How do you help them very quickly to make decisions about their goals of care? There were ethical issues as well. How they have to make decisions about who gets treatment when you have this overwhelming crisis And a little bit later, we're going to look at triage and how palliative care can integrate into the triage. Is it how do you decide who gets the resources? And I'm sure in India, as we are seeing in South Africa as well, with COVID, with the COVID pandemic, there is a very real scarcity of resources. And the whole time people are having to make a decision who gets onto a ventilator if ventilation is needed. So communication was what came out from the humanitarian health organizations as their highest need. And I think that is something that we in palliative care, we know how to talk to people, we know how to talk to families, we know how to talk to patients when there really is that this patient is coming to the end of life, and it could be this little child, this could be someone who is healthy and because of what has happened is suddenly faced with death. We have those skills, we have that knowledge, so that is something that we can share. And then of course, while the medics were really good at symptom management, we also come in with looking at the whole picture of where the patient is, what the context is. And so we may have another approach to symptom management, especially holistic symptom management there. Psychosocial care was a really interesting one, because if you're looking at the UN and WHO agencies, there is a very big department that looks at mental health and support. So while we are pretty good at doing this holistic care, we find that in some areas we have to say the real experts are coming from WHO. How do we as palliative care practitioners, with our view of psychosocial care, how do we integrate with them? Or are there times when we need to stand back and say, let's focus on something else, on another aspect of palliative care, and allow this group to come in? So again, it's teaching us as palliative care professionals about how to actually be more collaborative. You know, we say we're collaborative, but if I look at palliative care and hospice programs in so many places, they're very self-contained units. So that is something that we can learn from as well. And then, of course, the overwhelming needs of spiritual needs that these people have. We know from working with individual patients and families how often that question is, why me? Why is this happening to me? What meaning can there possibly be in this humanitarian crisis? How do we provide the spiritual care? How do we work with those agencies that come from a spiritual care background, like World Vision, like the major organizations that come from the different faith groups in different parts of the world? How do we as palliative care practitioners either collaborate and work with them to do spiritual care assessments and to look at spiritual pain and to support people spiritually? So that was an important area that we really felt. And then, of course, my interest in spiritual care of children, because children is so often left out when we're looking at spiritual care. You know, people say, oh, children are spiritual, yes, but we'll say a little prayer with them, or we'll do some kind of religious intervention, and it's not enough. So spiritual care across the ages, from that tiny little newborn to the very elderly who are having to face this horrific situation at the end of their life. And then, of course, where we should be the experts, and we really should be the experts, is end-of-life care. Remembering that end-of-life care happens very suddenly to so many people in humanitarian situations. And families are having to come to terms with this, and the person themselves, and especially where they are triaged into what they call the expectant group. This is the group that is expected to die, where those who are trying to save lives are too busy to provide that support at the end of life. So that's a huge area where we need to see, how do we do that intervention? How do we integrate it into the community? How do we integrate it into the health responders to provide that end-of-life care if we as palliative care practitioners are not there? And I think this is a challenge to us all as palliative care practitioners. You know, we can't lump everything onto the humanitarian health responders. Where are we visible in these situations? And then the issue of support. Staff support in any kind of situation we know is important. It's something that we as palliative care organizations and practitioners, we know it's important. We don't often do it that well, but we know that it should be done. And when you are faced with these overwhelming number of deaths, overwhelming number of people suffering, how do we come in as a palliative care movement and provide the assistance that helps those to cope in these traumatic situations? And of course, we know there are many, many barriers. And why has palliative care not been seen in humanitarian situations? And if we look at ourselves, I think one of it is that we haven't thought about it. And really that was what came out from so many people from the palliative care field. Oh, we hadn't thought about doing that in humanitarian situations. That's the job of Médecins Sans Frontières. That's the job of the Red Cross and UNICEF. But it's our job too. So part of it was not having thought about it. Part of it is fear, because do we really want to go into an area where there's war, where there's a volcano erupting, where there's serious floods? So it's either being practical and sensible, you know, having families and people who depend on us. So we need to learn courage from our humanitarian health responders as well. And then it's like priorities. As a palliative care community, we are here, we're passionate about it, we know the value of palliative care. But if we look at the size of the palliative care community across the globe, we are still a relatively small group of people who are passionate and who are driving palliative care. So until we integrate it into everybody's practice, we're going to remain this fairly small group. And there are so many needs. There are needs within our own community, within our own region, within our own country, already for palliative care practitioners. Can we spare the palliative care practitioners to go into this new field? So we have to ask ourselves that as well. I spoke to you about the lack of resources. Now, I'm fortunate in South Africa, where, in fact, I can remember from my nursing training days, which go back a long, long way, up till now, we've never really had a problem getting opioids and getting morphine. Excuse me. And we still don't. But in most countries in Africa, morphine is very, very limited. So we have to say, if we're not allowed to take opioids into the country, and opioids aren't available in the country, and pain control is something that we as palliative care practitioners feel we do so well, how are we going to cope with that? And it's like, you know, almost having your right arm chopped off because we don't have what we depend on to do our care. And then I'm not going to go into all of these because I think this, you know, just looking at it, and I'm very happy for you to have these slides as well. But I'd like to highlight the group that put this together, which is a group that is based in Montreal, the two great universities there. And it's the Humanitarian Health Ethics Group. And if you are interested in this field, it is really worthwhile joining that group or going into their website, because they have done some amazing research and really do produce some really good webinars that you can follow as well. But then, of course, I was quite interested. I'm going to be giving a similar talk later this afternoon. And the National Hospice Movement, the first thing they said, oh, maybe there'll be funding available. Well, I hate to pop their bubble, but funding even in this field is very difficult to get hold of. So funding limitations is another thing. If you can't afford to fund yourself to go and work with Médecins Sans Frontières, the chances of you getting a job with them are not really great. All of these organizations expect you to volunteer. So if you're just getting by, you may not have the funding to participate as well. But as I've said to you, there's always the light, there's always the helpers, there's always some kind of support that we can get. And that really gave us hope in the beginning to work in this field. So first of all, we saw that in many different countries, and some of the poorest countries, and then some of the richest countries in the world, that there were initiatives. Many of these initiatives were helping refugees. And we talk about refugees and refugee agencies almost being the low-hanging fruit for palliative care integration, because these are more stable and settled communities. Some refugees stay in refugee settings for 15, 16, 17 and more years. So refugee settings are sometimes very long-term. And you can see a number of the countries where things were actually happening. And then there was an increase in developing guidance material, and I'll talk about that a little bit more later. And the most exciting thing of all was the Sphere Handbook, which is a handbook of standards for every type of intervention in humanitarian crises, included for the first time about 3 years ago, a standard on palliative care. A very basic standard on palliative care, very focused on end-of-life care, but it was a tremendous beginning for us because all the humanitarian agencies use the Sphere Handbook standards. So here are some of the publications. As I've said, the Sphere Handbook, and then a number of us were called in to help to develop a guide for the World Health Organization. And this guide can be found on their website, and it is available free of charge. So it's a really good way to start and to get a bit more understanding about the field. And then the field manual for palliative care and humanitarian crises. Originally, you had to buy it to be able to use it. And when COVID really started, I was very fortunate in that I approached Oxford University Press and asked them if they would give the field manual online. So in the beginning, they gave us 2 chapters. But when we went to them later on and said, the 2 chapters aren't enough, we really need the whole book, they very generously put the whole book online free of charge. So these are 2 excellent resources that you can access free of charge. And then we had a review of the literature that we've mentioned before. These are the 2 that I spoke to you about, the Sphere Handbook, which says very simply, people with a progressive life-limiting illness approaching the end of their lives, and this is the part that we want to change, have access to good quality care that focuses on improving the symptoms, the dignity, and the quality of life. So it's not bad, except we need to broaden it to be more than approaching the end of life. So when we look at these emergencies, we look at, as we've been already looking at them, we look at the population that needs to be served, we look at the different cultures, the different beliefs, the different access to resources. We look at the whole context. Is this an acute crisis like the tower block collapsing, like a fire, like a volcano erupting? Or is this a long-term unrest, war context as well? The resources in the country and out of the country, and then how is this collaboration going to help to work? with the country internally and with all these external groups who come in to assist. And there can be very many groups that are involved in working in humanitarian emergencies. The people we know, it affects everybody. They all suffer loss. They're all traumatized. Many will have chronic illnesses, especially your older community. So we have within a vulnerable community, we have many who have extra vulnerabilities. Your elderly, your children, those with disabilities, those with any kind of rejection, any condition that causes rejection. And we have all of these mental health problems that come about. We see complicated grief in a large scale. If you just look at everything that has been lost, how their lives change, sometimes just overnight, we can imagine how much complicated grief there will be, and that grief that they will carry throughout their lives as well. And at the same time, often those structures that they take for granted, the spiritual support structures, their religious structures, are all impacted and cannot provide the same level of support. The traumatic experiences that the children undergo. I mean, this is a refugee child's drawing, and isn't it horrific that the drawing is about dead people and people being shot? And children shouldn't be drawing these kind of pictures. And then how do we care for our dead? You know, in different faith groups, we have different ways of caring for the dead. And it's really important for us to do that. And yet in these situations, it can't be done. There's an interruption in what we see as our traditions that we've grown up with, which are part of us, which are part of our religious beliefs. And then I spoke to you about, I really think that we as palliative care have to work with the UN, the WHO resources, because they are excellent. They are in many different languages. They are culturally sensitive, and they link with people in the different areas of the world. I've spoken to you about the spiritual distress, the emptiness. What is the purpose of this? You know, I was a professional, I had a job, I had a family, I had a home that I'd paid for, I had my children that I was educating, and suddenly all of that is gone. All those things that we're connected to have just disappeared, or I've had to leave behind. I cannot even begin to imagine the distress. And so that is why those organizations that look at building spiritual strength, that look at spiritual distress, are so important. That all the faith-based organizations from the different religions and different faith groups. And then my particular field, and where my passion really lies, is children. What is happening to the children? The children who are exposed to trauma, they're exposed to fear, they lose their parents, everything that gave them security has disappeared. And I really, really love what Anthony Lake, who used to be the CEO of UNICEF, said, and this was in a war zone. He said, what they're trying to do is to give children the simple miracle of an ordinary life. And we're really fortunate in that children, actually, they respond very, very quickly and more easily than adults to interventions that are done for them in the humanitarian settings. And there's some lovely work going on in helping them with education, of course, with helping them with grief counseling, but also helping them to express their feelings and their emotions through art and poetry and music and those kind of things. And play. It's so important that we play and we allow these children, that there are safe places for these children to play. And that's something that we in pediatric palliative care, it's an essential part of pediatric play, palliative care. And art, of course. And it's not just for children. Art is really good for adults as well. So We know where the humanitarian crises are. We can't miss them. We have an idea of the palliative care needs now. The one thing we don't know is how many people in humanitarian crises actually need palliative care. We know that there's increased illness, morbidity, and mortality in these settings. We know that people develop serious health conditions within these settings. There's an increase in premature babies being born because of the external stresses and the external traumas. And there's a reduction in the services for these babies and for these pregnant women as well. And so we also know that there's this huge group who are bereaved. When we looked at the refugee crisis in Cox's Bazar in Bangladesh, and the wonderful Dr. Fazana Khan, that some of you do know, that she went into the situation and she said at the time, I feel absolutely helpless. I don't know how to stand beside them. But she didn't stop there. Fazana went ahead, and with help, she and Megan Doherty, they carried out a rapid assessment, the first rapid assessment that had been done there. And they found some really interesting things. First of all, of course, they knew there would be no palliative care provision. They noticed the intense emotional and spiritual suffering, but they saw a very high proportion, a very high percentage had pain. So all of these things say palliative care is needed. The suffering, the pain, there was a lack of medicines. And because they had to pay for these medicines, poverty was a huge factor. And 94% of families did not know how to provide care. So when you know what the problem is, you can actually plan to deal with it. And so they went ahead. And there's some really good publications. Again, if you go into the Palchase website, all of these publications are available to you. And I would encourage you, if you're interested in this field, to make use of the Palchase website. We are continually putting new materials up there as well. So all of these things were needed: pain treatment, medicines, training, home-based care, and management plans. And especially they worked on developing community-based programs. And there were many people who wanted to help, regardless of the fact that they were in refugee settings, that they had left their home. There were people who still wanted to reach out and help. And so once you identify those are the people you know that we are going to train to be community health workers. And they had a 10-day basic training. And then they went into the homes and they could identify people who needed palliative care, who could then be referred to a palliative care team. And they found they were absolutely the core. And I think you in India, and we certainly in Africa, know that our community care workers, our community health workers, are the backbone now of our health services. And there's just Fazana in the middle with some of her palliative care assistants that had been trained. And so they were able to improve the health literacy, to guide the patients and helping them to find out how to access the health services, and then physically helping them to get there as well. And then, of course, really important, the adherence to the recommendations. So if you've got somebody coming in regularly, and this is something we know from both our countries, is it's going to improve adherence. So education and training was really important. A manual was developed for the workers, and I really want to commend the work that Fazana and Megan did. They produced these materials in no time at all, under pressure. They looked at what was essential, the essential medicines and how to get them in. And I'm not going to go over this because it is something you will find in the guide. But they did find that involving the local community as early as possible, doing the training, not allowing communities to become dependent. They must become independent. They've got to carry on after these organizations pull out. And collaboration was absolutely core to what they were doing in Cox's Bazar. So we need to ask ourselves, the questions, will there ever be adequate palliative care resources? And the answer, I think, not in our lifetime. So how do we expand what we have? And of course, we know there are no quick fixes. We know that we can't suddenly have palliative care being provided in a community where it was not there. And so building the community's capacity and training local people is going to take time. And it's going to take us to get involved as well. And we are living in this wonderful world where we can connect virtually and so much can be done. So if we can't go there, perhaps we can help with training, perhaps we can help in some other ways with research, with education, with developing materials. A present situation, 34 conflict-affected and fragile countries, according to the International Rescue Committee, could see up to 1 billion COVID-19 infections. And remember, these are areas where the vaccine rollout is either non-existent or very, very slow. We know that in the Rohingya camps that there has been an attempt to get vaccines there and to help people to be protected. And so there's been a big rollout of education, of ensuring that there are adequate resources in the different refugee camps, not just for the Rohingya, but also around the world. And to increase the awareness of palliative care. This is coming from WHO. Dr. Tedros said palliative care is essential to the humanitarian health response. But words are easy. It's actually seeing that something happens. And you see where they say palliative care for the hopelessly injured. We want people to see as palliative care as much more yes for the hopelessly injured. And I really don't like that term hopeless. The cleansing materials and teaching the children to wash their hands. The World Health Assembly saying that palliative care is essential alongside testing and treatment for COVID. And the governments must see that this is included in what is happening in refugee camps. The Global Palliative Care Organizations got together last year and we produced a whole series of webinars and briefing notes. And so again, on our website, on the globalpalliativecare.org website, you will find the briefing note. Very, very shortly and succinctly has set out how we see palliative care in refugee camps and humanitarian settings. So what does the future hold and what does palliative care look like with the COVID pandemic? How do we develop safe care when this infection is changing and spreading still, despite all that has been happening? So what we've looked at is taking our values forward, which will help with ethical decision-making. One of the most powerful stories I ever heard was I was invited to go to Turkey by the Syrian American Medical Society. And there I was privileged to see what they were doing and to meet with many people. And there was an obstetrician who was the last one in a particular area of Syria. And she was working in an underground hospital with the bombs exploding outside. And she was faced with a dilemma that as everything was collapsing, 2 pregnant women who needed Caesars came in to the last little area where she could operate. And she had to make a decision then and there which one she would operate on and do a cesarean on, knowing that the other woman and the child would die. And I think to be faced with that kind of ethical decision-making without any kind of background support. So this is where we as palliative people can come in as well and to help with all the distress. You in Pallium India and in Kerala showed how palliative care could be integrated. And you have that amazing training course, which is available as well, which is really, really excellent. We know that we can integrate palliative care into the different triage categories. So this is how the humanitarian groups triage people. Red is immediate. So if you get in there and you treat them, then their survival is highly likely. It's possible. So that's going to be your priority group. Where do we bring palliative care in? It might be around communication. It might be around pain management and symptom management. It might be around supporting the family. So there it is possible to bring it in. But in the groups where the treatment might be slightly delayed because there's not an immediate danger of death, or who will need some kind of medical care. Perhaps they've broken a bone, perhaps they've got crushed ribs, perhaps they have got soft tissue damage that can wait for treatment. There we can come in with pain and symptom relief and with psychosocial and spiritual support. And then the group where the humanitarian groups would like us really to become involved is the blue group, the expectant group. Those who, they say, within their resources, within the care that can be given, survival is probably not possible. This is where they would like us to become very involved. But that will mean training of others. It will mean training of the community. It will mean some of us going in and doing that as well. So training, of course, is really important. And we do have a training curriculum. It has already been rolled out to about 300 different people. And we are hoping that WHO will allow us to work with them to develop one that can go onto the WHO platform. Advocacy, so important. And WHO, the UN, recognize the value of palliative care, but we have to keep on showing how we can care for the most vulnerable. The most vulnerable, the children and the older persons who so often get affected. And of course, as an older person myself now, I'm really keen that palliative care is properly integrated into the care of older persons. So what our recommendations are is that palliative care, and this is to the humanitarian health workers, is it should be integrated into all humanitarian health responses, into the health and social systems that are set up in these crisis situations, and totally part of the humanitarian response. We recommend that guidelines are developed, and we have the WHO guidelines, which have their limitations, but they're pretty good. We have the field manual, but there is definitely a need to look at more, especially for the more vulnerable groups. How do we provide palliative care for children in humanitarian situations? How do we do it with older persons, with those with disabilities, with pregnant women and neonates? We need to ensure that the essential palliative care package, as you will see in the guideline, as was in the Lancet report, is available when going into a humanitarian crisis. And of course, that would include opiates and the ability to provide proper pain control. We recommend that within the rapid response teams, the palliative care practitioners are included. And we recommend that the training is ramped up as much as possible. And with our modern access to virtual training, we are really in the right time for doing that. But we also feel that the humanitarians have a role, and we have so much to learn from them. We learn from them working under pressure. One of the things that we're often proud about in palliative care is we have time. We have time to sit alongside patients. We have time to sit alongside families. Well, in humanitarian settings, you don't have that time. How do we bring those principles in and provide them to those who need it, working under this time pressure that we have? We're knowing that we have to move from this person to the next person to the next person. And maybe we need to learn from them, how do we set boundaries and how do we make time frames and say we can do so much, and after this amount of time, the community, the country has got to take it over. And that's something we can learn from Médecins Sans Frontières, because when they go in, they say we are going in for a certain period of time. And within that time, the community will have to learn to cope. Do we do that with palliative care? We tend to push our boundaries and to expand our timeframes. It teaches us as well to look at the really big picture, not just the big picture of the family, of our community, but the really big picture of all the different parts of the puzzle that come together to make up the humanitarian response, and how we can fit into that bigger picture, how we can be an interlocking piece that interlocks and collaborates with so many different groups and organizations, and how we can work within these humanitarian hubs that do get set up by WHO. We know about ethical decision making. We know all of the steps that need to be taken. We know that we should have ethical committees, which implies that we have time to talk. As I said to you about that doctor in Syria, she didn't have time to make a decision. She had to go through all of those ethical steps very quickly. Will you excuse me for 2 minutes? I must just get some water. Sorry, I should have had the glass of water. I wasn't prepared. Then, of course, triage. You know, we triage our when we have lots of patients in our programs? We do have to triage, but maybe we can learn from that. And then quick training. You know, when I first started with this, I can remember the Syrian American Medical Society asking me, now, how long does it take to train a community worker? And at that time, we were doing a 3-month training, and they just looked at me and they laughed. They said, there isn't time for that. How do you condense your training to make sure you've got people who can do the work, but get trained very quickly? And then, of course, I think what we need to learn from them is courage. Courage to go into these situations knowing that so often that they are dangerous situations. And Smriti and I both know Sophie, who I showed you right at the beginning, who goes into these situations, whose dream is to work in the most war-torn places. I mean, she's just in the last year, she's been working in Somalia, in Lebanon. She's now in South Sudan, and she's eyeing Afghanistan. Where does that kind of courage come from? I don't think I would have it, to be honest. And we need a global strategy of collaboration. We need to recognize, you know, we can become very much sort of proud of what we do, and we should be proud of what we do as palliative care people, but to see palliative care as almost separate from everything else. And we need to accept that it's a necessity in a humanitarian crisis, but perhaps saving lives, we can understand why that might be the priority for the humanitarian health response. But we can bring in our principles of compassion, of connectedness that we share with humanitarian health workers. We can bring that to strengthen the work that is being done there. We need to work together to advocate, not just palliative care people, not just people who are working in the humanitarian group, but the cancer groups, people with disabilities. We need them all to advocate for palliative care to become part of the humanitarian response. We definitely need a lot more research, but there is, it's really exciting to see. I get a lot of emails, I get a lot of requests to chat to me about different areas of research. So I think research is becoming a very important part of this humanitarian response, and we need education. So we have education, but it needs to get out there. We all need to have education on humanitarianism as part of our palliative care curricula. And then, so if anyone would like to join us, and we're having a series of webinars on experiences from the field, where we get people who've worked in the field, who are working in the field, to talk about their experiences. And on the 21st of July, we have Vicky Opia, who is a nurse who's done fabulous work in northern Uganda, especially working with refugees from South Sudan and from the Central African Republic. And then we have Dr. Sakib Bertsa, who is a technical advisor to the Médecins Sans Frontières and who has vast experience of working in different areas of the world. And you would have to look and see which would be the best time for you. But if you're interested in this field, I would encourage you to join our webinar. And just to end up with some words of Fazana, which I think are beautiful. Nobody seems to care for these human beings and their unfortunate families. And whatever we do needs money. But then she challenges us and says, can we build up a strong palliative care force who will be a light to these absolutely disadvantaged people? So let's be the light. Let's be the light for these absolutely disadvantaged people. So thank you. And I'm very happy to answer any questions if I can, or to find out the answers from you if I can't.
Thank you, Joan. Thank you very much. Thanks for a very, very enlightening session. I think you really, driven home the point that there is room for not just palliative care in humanitarian crises, but also a place for everybody in some way or form. So if I may ask everybody to turn on your cameras if you can, so we can see your faces. Always nicer, especially after 1.5 years of Zoom fatigue. It's just nice to see humans on the other side. Joan, may I ask screen share? Thank you. Perfect. Lovely. Okay. Oh, I see some friends all the way from Uttarakhand. Okay. All right, great. So just a couple of observations and some additional comments before we go into the question answer session, Joan, if I may. It's okay if you can't turn on your cameras. It's okay if the bandwidth doesn't allow, or if you have people running around behind you. It's okay. You talked about marginalized communities, and I want to just recall an experience we had in Kerala last year when the hard lockdown happened. And one of the things we found was that especially elderly people living alone had a very hard time getting access not just to their usual needs, but also those who were dependent on medication for chronic conditions like diabetes and things like that. And it's in a situation like where we're still experiencing, there's a third wave predicted in India and things. It's also good for us to be mindful of the fact that to check in on your elderly neighbor who hasn't probably been able to get out and get themselves basic stuff. We put out a call in the newspaper asking for 20 to 40-year-olds who had vehicles, if they would like to volunteer with us in order to reach these people who we couldn't, in areas that we couldn't cover. And it was amazing that in 24 hours, we had 87 volunteers show up. And because of them, we were able to reach out to people in the community, get them the medication, get them food rations, get them groceries, all of those things. So that is also a humanitarian response. And that is exactly where the community plays such a pivotal role of bridging the gap that even we as healthcare providers, we can't sometimes get to certain populations. And also important to remember that manageable conditions like diabetes can actually spiral into life-threatening conditions if people don't get their medication on time. So that's one aspect. The other thing I wanted to share was a very poignant exchange I had with somebody where she was a transgender woman, and we were having, she's a doctor, and we were having a conversation about essential medicines. I was worried about the supply chain getting disrupted and people not getting access to pain relief medication. And, we call them essential medicines. And she turned around and said to me, but Smriti, do you know what is an essential medicine to me? It's estrogen. And in my years of working in palliative care, I had never thought of estrogen as an essential medicine. And that was such an eye-opening experience for me. So it's not, we need to also expand our own horizons and see what really matters to the other person and not make I realized I was making assumptions at that point about what was essential and what was not. So that was a very, very important lesson. the other thing I wanted to really sort of emphasize what Joan said was, when we go in with the intention to help, the intention should hopefully also include the idea that that community needs to sustainably look after themselves after a point, and we can't become indispensable crutches. So it's great for us to be available when they really need us, but also part of our service should include a component of how can we make life more sustainable for them in a way that they're not constantly reaching out to others for help and assistance. And that was something that really resonated with me, Joan. And finally, I wanted to just highlight one particular issue in India. And Joan and I had the opportunity and the privilege to be part of a small group of people who talked about this, the plight of children in the COVID crisis in India. And I mean, I know all of you at some point or the other have experienced, on social media, all those calls going out, okay, this child has been orphaned, or this child is now alone, and this child is by themselves, and who would like to foster this child? And it took a while for the message to get out that is actually a very dangerous thing to do, because especially in a time of crisis, child trafficking and abuse of children can really exponentially explode, because not everybody, unfortunately, is well-intentioned. So really getting in touch with the authorities who have the safeguards in place to ensure that these children who've already suffered incredible amounts of grief and despair and stress are not subjected to further abuse because of misplaced compassion that we might have. So a message that I'd like to leave with everybody is always try and do the research into how safe a certain intervention is for the person who is already in a crisis situation. And those checks and balances very often need to come from the community level. And that's something I just want to leave on the table there with all of you. Joan, I'm going to kickstart the question answer round, if I may. You talked about the Sphere Handbook, and the Sphere Handbook, the links to the Sphere Handbook and to the Field Manual for Palliative Care have been shared in the chat box. You can just download that link, but it will also be shared in the WhatsApp group that all of you are on. Joan, I'm just coming back to the concept of triage. And my understanding was that traditionally in humanitarian crisis settings, especially disaster management and all of that, when we talk about the allocation of limited resources and how they're distributed to people with maximum chances of survival, that already puts the palliative care cohort very low on the rung, right? So you did talk about those different triage levels, but this is something I think if you could just talk about a little bit more and help us as lay people understand what should we be advocating for.
I think when I look at it, I can understand when you've got limited resources that saving life is going to be a priority, and preventing further disability. So those are the priorities of the humanitarian health response groups with limited resources. But this is why we looked at where could palliative care come in with that particular group, but where could it come in with all the other different groups? Those that can wait a little while, they're not they don't need immediate attention, but they will need some good medical attention. Those that have been shell-shocked, who've got grazes and bruises and things that can need attention, but they can wait for a long time. But then the group that they call the expectant group, which is the group that is going to be left without any interventions, any medical interventions, because their resources are limited and their priority is saving life. And they wanted us to come in and really just focus on that group. But we wanted them to have an idea that palliative care could actually be integrated all the way along. We know that if we have limited resources for palliative care, that is the group we probably would be focusing on. So if you and I went into a humanitarian crisis and we had Médecins Sans Frontières looking after those that could be saved, we would probably focus there. But what we want them to do is to integrate principles of palliative care into the way they communicate, even with those who they are looking to, whose lives to save. So how they can communicate, give them support, emotional support. You know, in acute emergency, you're not going to be thinking about spiritual support, but actually giving that support gives that life meaning. So I see any intervention actually as having a spiritual aspect as well. And certainly with the other categories who can wait a while, they would need the psychosocial and the spiritual support, and maybe some symptom management as well. But, you know, as I say, we're still looking at how we can get them to accept that palliative care could be part of that saving life and preventing further disability, where they want us all to be with the expectant group, because they see palliative care as end-of-life care. As you saw, the hopelessly injured, which I think is a horrible, horrible sign.
Yeah, truly.
Yeah. But as
Prati, namaste. This is Mudra from Mysore, and hi, Joan. Probably, I would like to share one incident as well as probably a question to you. This pandemic has really taught us a lot of lessons. The triaging has been a very, very difficult position. Now, the ethical questions will always be there. Am I letting go a wise person at the age group of 50 or 55 who can still contribute for the society? Or I'm letting go a child who is at just 5 years or 6 years, who has not seen the world at all? Now, how do we decide these things? What are the tools the medical profession has to decide? This is one question. And the second, the kind of this, you know, the response as non-medical people, what we can give. A very, very wonderful, very, very heartwarming response, what we got in our palliative care center when the first, this, you know, the wave occurred and the huge migration started, labor migration started. One of our patients who was suffering from liver cancer, 4th stage, he made himself available in his locality. A person with a below poverty line person, this, you know, segment, he arranged resources for nearly 300 food packets for about 36 days. It was an amazing experience for us to see that a person who has got limited resources for himself, but he could mobilize the society to do that job. For 36 days, he did it. And we lost him about 3-4 months back. An amazing person who understood the life, the meaning of life at the time. All our team was in tears to see that, this, you know, the person doing that job. You know, there is absolutely, there is no lack of resources at an individual level. I think we lack resources at the collective level. Probably there is a need to make a concerted and coordinated effort to bring in collaboration with government, NGOs, and other individuals and corporates and whatever it is. But only thing is whether this can happen within overnight for that emergency response. Probably this is what we need to look at.
Yeah.
Thank you.
Absolutely. Thank you. Thank you so much. And thank you for that wonderful story and that wonderful man. And I'm sure what he did gave meaning to him as well, made him feel as though he may be end of life, but he still has, he can still reach out and help others. And I'm sure it helped him as well as helping so many others. And it reminded me, I had a little lady who was dying of renal failure. And when she had a good day, she would get up and she would make jam. And when you'd go there, she would give you all these bottles and she'd say, please give to the other people who are sick. And that gave her life meaning. And so I think it's wonderful. And we often don't think of involving those people we see as our patients in these kind of responses. And I think that must make us think more of that. You spoke about the ethical decision making. Well, in palliative care, we have our ethical principles that we follow. And normally in a palliative care setting, we will sit and discuss it. We will look at, beneficence and non-maleficence and autonomy, all of those things, and we have time. I think what they have to do in crisis situations, as that obstetrician had to do, faced with the bombs come falling down outside, 2 women who needed a Caesar, knowing that one of the women and child would die, had to very quickly make an ethical decision as to which woman she decided on. And, the story was incredibly powerful. And I didn't have the opportunity to ask her how she came to that decision. But I think it's maybe we need to practice. Maybe we as palliative care people need to say, if we were faced with this decision that we normally would sit and talk about and come together as a group with a final decision, if we had 3 minutes to make that decision, how would we use the tools that we have, which are the principles of ethical decision making? How could we do it in 3 minutes? And maybe it's something that we have to practice. I don't know. What do you think, Smriti?
I think so. And I find that every time we're put in these difficult positions and are made to practice exactly this, I think that's what refines our own inner compasses also. So yeah, I don't think there's a one size fits all sort of answer. It's really case to case. It's really what is available at the time, and it's really what we're able to do. But it's a question worth thinking about over and over again. So thank you, Mr. Ramakrishna, for that.
Thank you. That was a lovely question. Yeah.
We have a question about spirituality in children, but I also realize we have 3 minutes. So I just to let Sunita know that further down this program that we're running now, the series, we're actually going to be having a special section on children. And I'm also very delighted to say that it's Joan coming back to talk to us about kids.
So we will be talking about spirituality in children, believe me.
So we will hold that for that session, because it's really a whole new universe as well. So if that's all right. Any other questions or even reflections are welcome. There is something here. Joan.
I'm looking at that last one, and I think that is that has political ramifications.
That has political ramifications.
It does. And I wish I had the answer to that, about how to protect resources that are collected from being abused. I don't have the answer.
One thing we can do, which is harking back to the point that I made earlier, a large part of the onus of responsibility is ours to do the research and to really diligently vet the organizations that we want to support. And we see this happen, that a lot of organizations, so-called organizations, spring up overnight saying that, okay, this is where the aid is going, etc. And then there's no accountability, there's no tracking, there's none of that. So there are more than enough established organizations, and you can actually take your pick, where there are those that are geared towards children, women, the LGBTQI community, people who are ill, and a little in the absence of those kind of assurances, and like Joan said, it's a politically charged issue also, because it varies from country to country, state to state, community to community. And so if we can actually take the responsibility of researching the organizations that we want to support, that's one small way in which we can be assured that what we are contributing to is actually reaching the people. Because organizations who are really invested in doing this have a system of accountability in place, or they should. If they don't, then maybe you should look for an organization that places importance on that. Joan, there's a question about from Rachel, who works with people with disabilities. And her question is, I happen to hear you mention disability along with palliative care. Does Palchase have a place for people working with disabilities in the organization, or do you know of any such similar organizations working with those affected by humanitarian crises?
Rachel,
you've just responded.
Sorry, I wrote there, but I forgot to say to you that if you go onto our website, there is a place where you can join, and you have a special interest. We would fit you into one of our groups. We would love to have your voice as part of Palchase, because that is an area we realize, needs a lot of attention. And at present, we don't have anyone working in that field as part of the Palchase network. So we would be delighted if you'd like to join. But anyone can join Palchase. It's absolutely free. You can go to our website, palchase.org, and you'll see there is a button that helps you join.
And if I may also add, Rachel, that there is a concerted effort now to integrate working with people with disabilities, disability rights, etc., with palliative care, because in a lot of what we call the global north, which is countries that have high resource settings and have high income countries, there are specific verticals that cater to different needs. But in a country like India and in many low and middle income countries, we don't have that. So if somebody's even had say a spinal cord trauma injury and has been given the immediate sort of treatment, very often, especially if they're from very poor families, after a while they're just relegated at home. And and we've seen this around Trivandrum a lot, people who are in their homes with unmotorable roads, a house on top of a little hill, where this person doesn't have access to their own toilet. So we actually don't need to look very far to see how we can integrate just care for people with disabilities in our own communities, because it is a very, very, very invisible field. And I mean, at Pallium, we have over, I think, 70 odd people living with various spinal cord trauma injuries, as well as other people with disabilities. And there is a constant effort to integrate palliative care and rehabilitation and people living with disabilities, all of that. So plenty of room. Please feel free to connect with Palchase, connect with us, and we'd be delighted to have more people join us. So we are over time now. Joan, I can't thank you enough. Cannot thank you enough, as always. You are a light in this world. You're one of the lights you were talking about. And thank you, everybody who joined us today. We will continue to try and bring you sessions that you find relevant. And if you have questions still for Joan, please write into our team, and we will ensure that Joan gets those questions. And yes, you will see her again for the children's section.